Well, hello everyone, and thank you for being here today. My name is Sarah Elkins, and I work as the Northeast Regional Senior Campaign Organizer for Compassionate Choices. And I really just want to thank you all for being here today to talk about advanced care planning, end of life planning, and end of life options generally as it relates to you and yourself. If you are able to sign into the sign in sheet, that would be great. However, I know we don't have a big audience today, so that's totally okay. But I do want to be able to share these slide presentations with you all and make sure you have all of the resources, so we'll make sure you all have that. So to start us off, I want to talk about what exactly Compassionate Choices is. So Compassionate Choices is the nation's oldest and largest and most active nonprofit working on advanced care planning here in Massachusetts and all of the nation. We believe in patient-directed care, where the patient is informed of their healthcare options and are empowered to be in charge of choosing treatments in line with their individual priorities. So let's get right into it. It's important for you to plan for your future. However, before you can make plans for the future, we encourage you all to ask yourself some important questions. What are your values and your goals of medical treatment? How do you define life? And what matters most to you? What brings you joy? The Compassionate Choices My End of Life Decisions booklet, which I do have copies here for you all today, and hopefully we'll be able to leave some for you all so people have access to them. But this decision booklet is very helpful and will walk you through every single part of the decision-making process. It can be downloaded from our website, which you can see right down here, thecompassionatechoices.org/resources. You can also pre-order it on our website, which you can also do there. I highly recommend grabbing a copy and reading through all of this because it will walk you through every step that I'm about to run you through right now. Death finds us all eventually, and we can't prevent that. However, we can direct how we'd like our final days to unfold, and advanced care planning is the key to making sure that that happens. Making thoughtful choices now, putting them into a written advance directive, and discussing those choices with others, as in your loved ones or family members or friends, all of those things. Advanced care planning will help to ensure that we get the care that we want and avoid the care that we do not want, even if we're unable to speak for ourselves. An advance directive is a legal document that outlines these end-of-life priorities for you all. An advance directive typically includes a few different things. The first thing that it includes is a living will. So this is the what I want portion where you determine what you would like to happen to yourself if you were to become unable to speak for yourself. It's a written statement that details a person's desires regarding their medical treatment in circumstances where they no longer are able to express informed consent. And then the second part of an advance directive is a healthcare proxy, and that is the who will speak for me portion of the advance directive. In most states, you do not need a lawyer or a notary, but you may require to have a witness as you sign your legal document, the advance directive. And in Massachusetts, you do have to have a legal witness as you sign your advance directive. So everyone over the age of 18 should have an advance directive. There is a great disparity between completing advance directives and historically underserved communities. This graph on the screen is for everyone 18 and older, and if we are specifically referring to Americans that are 50 and older, these numbers look a little bit different. They look a little bit better. So about 44% of white Americans have completed an advance directive in comparison to 24% of Black Americans and 26% of Latino Americans. So there really is a huge issue of access in end-of-life care, and this is due in part to cultural and spiritual beliefs surrounding death. And if you're interested in learning more about these inequalities in end-of-life planning, I have a wonderful resource for everybody that's available on our website. It's called Advanced Care Planning and Disparities in Healthcare Planning, and that's one document that I highly recommend people check out if this is a topic that interests you. So it's important to choose a healthcare proxy that will advocate for your individual wishes. In selecting a representative, you want to ask yourself, are they assertive? Are they comfortable talking about death? Do they live nearby? In a crisis, having somebody local is and can be very important. Will they respect my decisions? These people need to understand where you are coming from and be willing to honor your requests, even if it's not something that they would want for themselves. Here are some options to consider. In some cases, it may be better to ask a nearby friend that you trust instead of a distant family member. Family may also become overcome by grief, and it may be difficult for them to have these kinds of conversations and actually value and honor your wishes by actually following through with them. You can consider asking a neighbor or a member of your faith community. Those are always people that are trustworthy to us. And when discussing your request, let them know that there is no financial liability attached to being a healthcare proxy. Your local senior services, like where we are today, the local Shrewsbury Senior Center, and elder care agencies may have programs that provide volunteers for this service. So there are many people that are willing to just be a healthcare proxy and value people's wishes if you don't have somebody that you know and trust. So these are some treatment options to consider. I just want to review these before we go over some other information. The first is artificial ventilation. This is often given to patients that cannot breathe on their own. So a tube can either be inserted in the throat a tube can be inserted into the windpipe or through the mouth, or through a hole that's made in the throat. And the machine pushes a precise combination of oxygen and air into the lungs at a controlled speed and pressure. Some people are given artificial ventilation and then slowly are weaned off of it, but many others are unlikely to recover after being unable to breathe on their own after having a ventilator. The longer a person uses artificial ventilation, the less likely recovery actually becomes. Another thing to consider is medications to stimulate heart function. Most people who experience heart failure need to take medication to regulate how their heart works or restart it if it stops. And people who are terminally ill may not want treatment to restart their heart if it would only prolong their dying process. And then the last point, artificial nutrition and hydration is the last one. So this is provided for people who cannot swallow sufficient amounts or cannot absorb nutrition through the stomach. For some who cannot swallow, a tube can also be inserted through the nose or surgically inserted through the abdomen wall in the stomach. This can provide support for people who have acute illness, but for people who are near the end of life, this often does not extend life and can cause additional medical problems and increase a patient's suffering in some cases. So these are all things that you want to have documented in an advance directive because these are all things that will impact your end-of-life care as you reach that time. So now we're going to talk a little bit about charting your wishes beyond a living will and beyond a healthcare proxy. So ambulance and hospital emergency departments and personnel are required to provide CPR unless they are given a specific directive that states otherwise. These directives are called do not resuscitate orders and are designed for people whose poor health gives them little chance of benefiting from CPR. These directives instruct ambulance and hospital emergency personnel not to attempt CPR if your heart or breathing should stop. Of course, you always want to discuss these kinds of things with your doctor because in many situations it's not the right thing to have a DNR. But in a lot of cases, people do want this because they don't want to prolong their suffering and they don't want to be resuscitated if it will just prolong their dying process. The pre-hospital medical care directive, or also known as out of hospital do not resuscitate form, informs emergency personnel outside of a hospital setting that if you stop breathing or if your heart stops beating, they are not to start CPR or use equipment, drugs, or devices to restart your heart or breathing. An attending physician will not issue an out-of-hospital do not resuscitate order if the person requesting the order is not eligible for it. So again, these are all conversations that you want to have with your doctor on whether or not this is right for you. Most physicians will only sign such a document for a person who is terminally ill or extremely elderly and frail, and mentally capable of making such a request for themselves. So this is not something that a healthcare proxy can decide for you. We recommend printing this form in color on a letter size, just so that it's easily found by any emergency personnel, and displaying it in plain sight in your home. So whether that's taping it onto your refrigerator or putting it on the countertop, laminating it and sticking it on the wall. You just want to make sure that if an emergency personnel comes into your home, they can see that order. It's also very good to have it on the colored sheet, like we have up here, because it makes it very, very present in the room. We also encourage people to carefully check out the care facilities that they are interested in to make sure that they will honor your wishes, your individual wishes. You also want to make sure that your wishes to stop medication and to stop treatments will be respected, and it's important that you confirm that you will get the pain medication needed to feel comfortable. On the Compassion and Choices website, you'll find these following resources listed above. The Sectarian Healthcare Directive, which stands to clarify that your wishes supersede those of any institution's religious policies, and that you wish to be transferred to a facility if they refuse to follow your preferences. As a slight side note, Catholic-affiliated hospitals have grown more than 28% over the last 2 decades, even as the number of secular hospitals dropped by nearly 14%. And an assisted living facility rider, which is a contract rider for people who live in assisted living facilities, would like to stay there until they die. This will ensure that an individual's home is suited to their choices. A hospital visitation authorization form enables people not traditionally recognized as family to gain priority visitation rights. And once these are completed and signed, these should be kept in your advance directive. And all of these can be found in the end-of-life planning guide that we have brought for you today. So that guide will be your advance directive, all of these other slight paperworks that you might want to fill out for you if it pertains to you, but all of these things will be drawn out for you in that guide. So when it comes to updating your advance directive, you should follow this rule right here. It's recommended your advanced care documents should be reviewed at a minimum when you start a new decade, when someone close to you dies, when you go through a major family change, such as a divorce, or if you receive a new diagnosis, or you experience a significant decline in your health. These are all reasons for updating your advance directive and making sure that it aligns with your priorities in that moment. Mm-hmm. While this is not a legal document, Compassion and Choices has created the Dementia Values and Priorities tool that will help you to identify your personal values and care wishes so that you stay in control even with a dementia diagnosis. Through this tool, you will be able to provide clear instructions to your loved ones and take the burden off of them when you can no longer make those decisions for yourself. I have, again, also brought some of those handouts here today. So if you're able to stop by and grab some, that would be great. But if not, that's also okay. You can also view this on our website. So if you go to compassionatechoices.org, all of these resources that I'm alluding to today can be found there. This is the most important part of this presentation. You really cannot do this alone. Not including your family and your loved ones in your planning will definitely leave them with regrets and questions after you die, and not including them will make it less likely that your plan, whatever it is, will be successful and will be respected. It's important to sit down with your family and have this conversation regarding your end-of-life decisions. And the Compassionate Choices End-of-Life Toolkit, which I've alluded to quite a bit, has some suggestions on how to have these conversations or how to start these conversations with your family. One of the ways that I'll allude to in starting this kind of conversation is to simply say the phrase, if you are ever in a position where you need to make a healthcare decision for me, it would be helpful for you to know what I really want. And again, you can find all of these tools on our websites. So what are the current end-of-life options that are available to you? You can pursue life-sustaining treatment for as long as you want to, until the very end. There's nothing saying that you have to come off of life-sustaining treatment, ever. But at some point, for most people, pursuing life-sustaining treatment is no longer feasible. So what's next? The patient can either refuse or discontinue treatment, knowing that it will lead to a 6-month prognosis for the patient, where hospice and palliative care is now an option. On hospice, you have 2 options of either VSED, which stands for voluntarily stopping eating and drinking, or palliative sedation, which is managing pain through medication that can accelerate death due to the patient's body being more comfortable. We know that, however, even though hospice and palliative care do wonderful things for patients, they cannot and do not alleviate all pain and suffering for patients. Medical aid in dying is one option that can help alleviate some of this mental suffering leading up to death. So, what exactly is medical aid in dying? Medical aid in dying is a medical practice in which a terminally ill, mentally capable adult with a prognosis of 6 months or less to live may request a prescription from their doctor for medication which they can choose to self-ingest to bring about a peaceful death. The process is authorized in 11 states, and including DC. So those are California, Colorado, Hawaii, Maine, Montana, New Jersey, New Mexico, Oregon, Vermont, and Washington, along with Washington, D.C. This means that over 1 in 5 Americans currently have access to this peaceful end-of-life option. So the proposed Massachusetts End-of-Life Options Act is modeled after Oregon's medical aid in dying law and is very similar to the laws in the 11 other jurisdictions where medical aid in dying is legal. The eligibility requirements of the legislation is the same across every state. So you have to be an adult, you have to be terminally ill with a prognosis of 6 months or less to live, which we also refer to as hospice eligible, and you have to be mentally capable and able to make an informed individual healthcare decision for yourself. And this needs to be verified by 2 physicians, and in Massachusetts, a mental health professional needs to also screen to make sure that the patient is able to make these decisions for themselves. And that's one of the many safeguards that are built into this legislation. So our bills, which are Senate Bills 1331 and House Bill 2246, an act relative to end-of-life options, includes many safeguards that ensure both the patient and the doctor are protected throughout this whole process. So in addition to 2 physicians and a mental health professional, ensuring that the patient is capable of making an independent and informed healthcare decision, which is the ultimate and final demonstration of voluntariness and independent choice, The individual must make the final affirmative and physical act of ingesting the medication into their body, such as sipping through a straw or pushing the plunger on a feeding tube or an enema. It is completely permissible for a medical provider or caregivers to hold the cup or the straw to a person's mouth, or pour the medication into the feeding tube, as long as it's the terminally ill patient themselves that makes that final act to ingest. There's also no duty to participate in medical aid in dying, both on the part of the prescriber and on the part of the patient. And there's no liability for medical providers if they are acting under good faith under the law. There's also no disciplinary action taken against any licensed physician by any state medical boards for participation or declining to participate in medical aid in dying practice. However, in Massachusetts, if a healthcare provider does refuse to offer medical aid in dying to their patient, it is required that they refer them to somebody that will. And it is always the underlying illness, not medical aid in dying, that will be listed as the cause of death on the death certificates. And this also means that the choice to request and take aid in dying medication cannot affect a person's health or life insurance status or contracts. So in the Senate for Massachusetts, we have Senator Joe Comerford as our lead bill sponsor to Senate Bill 1331. And in the House, we have lead Representative Jim O'Day and Representative Ted Phillips as our co-sponsors to House Bill 2246. These names and numbers may just be good for you all to have, so that if you are willing to reach out to your lawmakers regarding this issue, you can refer them to those people so that they can have further in-depth conversations about the legislation. In Shrewsbury itself, your senator is Michael Moore, who I think frequents here pretty often, which is nice, and your representative is Hannah Kane. And neither of these lawmakers have stated their support for medical aid in dying, for the medical aid in dying legislation that is currently pending. So how exactly can you as an individual help in this cause to make sure that people have access to end-of-life care that they want for themselves and also further our medical aid in dying legislation efforts? Your help is honestly very critical to ensuring and making sure that people are educated and empowered. People and medical providers are educated and empowered to make sure that terminally ill people in your community are not needlessly suffering because they either don't know about their options or their doctors don't know enough to provide them with the care that they want. We'd love for you to help, as real people and real families need this kind of effort. They need to know that people are on their side in this kind of endeavor, because talking about death is not an easy concept, so having a community of support behind them is needed. The first thing you can do is volunteer with us. We go around and do presentations like this to help educate and empower communities and medical providers about end-of-life care options. You can connect with us or community groups, community organizations that want to learn more and would like to present or have a presentation with a speaker on these topics. You can email your elected officials and tell them how important this legislation is to you, or how important end-of-life planning generally is to you. Because, again, these are not conversations that many people have within the legislature, not many conversations that happen in regular day-to-day life. So it's important that we circulate this narrative not only with each other, but with our lawmakers as well. You can write testimony in support of medical aid in dying and submit it to me, and we can use that for our committee hearing. And I can also call out that you can send supportive articles, such as the Boston Globe endorsement of medical aid in dying, to your elected officials so that they can see just how important this is to others. So I want to allude to just a few more resources that Compassionate Choices provides for you all. And again, you can find this all on the website. So this first resource, Finding a Partner Doctor, is a resource that will help guide you through an appointment with your doctor to discuss your end-of-life priorities. So it will really help to kind of give you those prompts that you need to start having these conversations with your medical team. And then the Doc to Doc resource is a free and confidential resource that you can provide to your doctor. If you're interested in having conversations about end-of-life options with your doctor and find out that they're not exactly familiar with the options that you are interested in, you can provide your doctor with this palm card, the Doc to Doc palm card, and they can use this to find out about the process of medical aid in dying and just get more equipped to have these end-of-life conversations. So it's a free consultation line. You can call at any point and somebody will get back to you within 24 hours. And this number at the bottom here is also the number for our end-of-life consultants, which you all can feel free to utilize as you would like. The end-of-life consultant line can help you navigate the nuances to the healthcare system. They can teach you how to interview a hospice so that you know if they align with your values and priorities. And this line can help to explain the differences between hospice, palliative care, do not resuscitate orders, advanced directives, MOLST forms, all of those things. It can also help to inform and educate everyone about the end-of-life options available to you in your state. So we also have a diagnosis decoder, and this tool helps you to generate specific questions for your doctor, nurse, or healthcare provider. And these questions are designed to get you the complete information that you deserve. Because, again, nobody knows more about you and what you want with your healthcare decision making more than you. And before we end and open up for questions, I just want to say that we really need you to lend your voice to the chorus of support for our vision of expanded options at the end of life. So if you haven't done so already, visit the website that's listed right down here, and you can sign up there to volunteer with us. This will allow you to be put in touch with other volunteers near you. It will also provide you with a timely and relevant resources, information, and materials so that you can stay informed and take strategic actions in support of the end-of-life options movement. And then I have provided up here my email, so if there are any questions from people in the room or online, you can feel free to reach out to me at this email address. And any questions regarding end-of-life planning, regarding your values, your wishes, regarding our resources, how you can get involved, anything you could ever think of, please just reach out to me and I would be happy to steer you in the right direction. Any questions?
Yeah, I have a question. Can you explain the legal lawsuit in Vermont? Can I go to, since I live in Massachusetts, can I go to Vermont and do this all and bring the medicine home if I need to or want to, or how would that work?
So Vermont did just get rid of their residency requirement. This is actually a really good question. They did get rid of their residency requirement, which means that you no longer have to be a resident of Vermont in order to get medication for medical aid in dying. However, you do have to be in the state of Vermont for your medical care, to ingest, all of these things. So you don't have to actually establish residency. That's the difference between having a residency requirement and not. So it's a lot easier for somebody to just go there and get the medication. You can't bring it home, but you no longer have to establish residency in your final days. Is that helpful?
It is, but I guess I'm honestly thinking, how do they know if you are bringing it home or not?
So it is, so providers typically know. They typically know because usually it's done in great coordination with them. So if you are talking with them about medical aid in dying, they will be asking you, where do you plan to ingest? what is your ultimate goal of all of this? Why do you want this? So they have a very intricate relationship with their patients. There's no actual real standard that says that doctors need to know where you are ingesting. So, in a sense, it's not super regulated. However, if you're having these conversations with your doctor, it's assumed that you will be in the state of Vermont. And if you're not, the doctors will not give it to you.
Okay, so we really do need to pass it in Massachusetts, is what you're saying. 'Cause
Yes.
first of all, you have to be well enough to get yourself to Vermont, which may not be the case.
Yes, exactly.
Okay, and what, if you know someone who has Alzheimer's, what are your suggestions?
For care
Mm,
or for planning for the end of life?
How do I word this? They won't be able to get medical aid in dying, period. End of sentence, end of book.
Yes, unfortunately, because one of the safeguards that are built into the bill is that you have to be mentally capable to make these own decisions for yourself at the time of ingestion. So unfortunately for people who have Alzheimer's and dementia, they are not in that state when it comes time for the end of life.
Sarah, do you know how those people usually die?
So
Like, you follow what I'm saying?
yes, so there are options for people. A lot of times, people with dementia and Alzheimer's will actually put it in writing that if they start refusing food and water, not to force it. And that's one of the ways in which somebody with a dementia diagnosis can actually control their end of life. So you can put that in writing in your advance directive. And that's really one of the biggest ways in which people who have dementia and Alzheimer's control their end of life experience. But beyond that, it's really about, when you are competent to have these conversations, you want to be having as many conversations around the end of life as you possibly can.
Right. So, I think I've heard that withholding food and water is very painful and very long process.
It is. Honestly, that's one of the reasons why we need medical aid in dying here, because for patients, not only dementia patients, the only option to end their suffering sooner is to voluntarily stop eating and drinking. And it really is a very prolonged process. It can take weeks.
And painful.
And it's painful. So a lot of people will do this they'll talk with their hospice or palliative care physicians in order to do this with support of their medical team to make sure that it's not as uncomfortable, but it really is not an option that many people like to take on. Yes, yeah. Because it's drawn out and it's
right.
It's also painful, yeah.
Right. So, our senator in Shrewsbury, at this point is saying he is honoring the 12-year-old referendum, and he wants to encourage us to do another referendum. So I guess I'd like to know what the likelihood of another referendum is, and what you might say to him, or what you think I should say to him.
So honestly, the likelihood of having another referendum is very low, only because it costs a lot of money, and for a nonprofit organization, it's not really super feasible for us to be able to front that money for another referendum, which is why we were really hoping that the 2012 ballot initiative would work out for us. Before I go into more detail about Senator Moore, I want to give just a little bit more information about the referendum. So we ended up losing that ballot initiative 49-51, and we only lost in the last 2 weeks of the campaign because our opponents, which was the Catholic Church, had overfunded us 4-1. And so even though we were overfunded 4-1, which is a very significant number, having the votes come that close and having it be 49-51, is very impressive, and it shows just how much people in the state of Massachusetts want this bill. In terms of Senator Moore, I will say that I definitely understand where he's coming from to not want to go against the ballot initiative. However, if you look at different polling numbers from 2012 until now, the polling numbers have significantly increased. We now have 79% of people in Massachusetts that support medical aid in dying, with a little bit of education on the safeguards and the built-in protections in the law. And so what I would say to him is that, you know, again, while that ballot initiative was unsuccessful for us, it's not reflective of the current campaign and the current landscape of what Massachusetts thinks about this bill.
Okay, thank you. What do you think the chances of getting this legislation, I mean, what kind of time frame do you see realistically? I don't see it progressing this year.
So we are actually in a 2-year session for the legislature. So if we do not pass it before January 1st, it just rolls over to the next session, and there will still be a vote next session. I will say that this year we have a lot more intel on lawmakers that are supportive, and we are gaining a lot more co-sponsors than we ever actually knew that we had. So there's a lot of momentum happening around the bill in both the State House and in the community, because we have a whole, honestly, this year has been great. There's been a whole grassroots movement of people just kind of coming out of the woodwork in Massachusetts who say that they support this bill and are now trying to help us lobby the legislature to help get this passed. So we're building support, we're getting co-sponsors as we go along, and we're having these conversations, like the conversations that you might have with Senator Moore, to move the needle even slightly forward. So I'm really hoping that we can pass it within this legislative cycle before the end of 2024. If not, I will say that we are extremely close to passing it, and I do not think that this bill will take more than 4 years to get past the legislature. Again, that's hopeful. However, just based on the work that I've been doing and seeing all the people that are supportive of this, I do think that we're going to pass it in the near future.
Thank you.
Of course, yeah. Thank you for your questions. And thank you all for attending today. Again, if you have any questions, feel free to reach out to me at this email here. You can also visit our website, compassionatechoices.org, to find more resources. But thank you all again for being here today. I really appreciate it.